Good afternoon and welcome to our inaugural Joint Department of Epidemiology and Public Health Grand Rounds and University of Maryland Greenbaum Comprehensive Cancer Center Population Science Seminar. It is my pleasure to introduce our speaker today, Dr. Marie Joseph Horner. Dr. Horner received her PhD in epidemiology from the University of North Carolina in 2018. Since then, she has held several positions conducting research on cancer epidemiology in the United States and sub-Saharan Africa, much focused on cancer among people with HIV. Dr. Horner is currently a staff scientist in the Division of Cancer Epidemiology and Genetics at the National Cancer Institute, where she leads scientific development and enhancement for the Connect for Cancer Prevention study. Dr. Horner has received numerous awards, including an NIH Merit Award. She has published 27 articles, many in high-impact journals, and has given numerous presentations at national and international meetings. Today, Dr. Horner will present on her work with the Connect study. At the end of her presentation, she has agreed to discuss pre- and postdoctoral fellowship positions in the Division of Cancer Epidemiology and Genetics at NCI with interested individuals. All are invited. You can simply stay on Zoom after Dr. Horner's presentation if you are interested. So without further ado, please join me in welcoming Dr. Horner to the University of Maryland.
So I'll take questions at the end, and we'll go over fellowship information at the end also. And so for the moderators, I can't see the chat when I'm in presenter mode, so I'm going to rely on you to let me know if there are questions that pop up. Okay, so today I'm going to give a talk about a new study at the National Cancer Institute called the Connect for Cancer Prevention study. In the flyer for CME credits, we have a few learning objectives, but rest assured, this is not actually a methods talk. This is a very applied methods description of contemporary and innovative approaches that we're using in this new study. Okay, so you may be familiar with the National Cancer Plan, aka the Biden Moonshot Plan, and there are 8 primary goals listed here, and you could find more information on cancer.gov about these key initiatives. So today I'm going to highlight how the Connect for Cancer Prevention study actually touches on several of these important goals for the nation, notably to prevent cancer, to detect cancers early, to understand and develop more effective treatments, eliminate equities, etc., and also to maximize data utility. So as I'll demonstrate in the talk, the study, it's not just about our epidemiology design. The whole back end of the study, the data ecosystem, is designed to be fair, so findable, accessible, and interoperable so that other researchers can use these resources without having to pay anything for it, since this is indeed a taxpayer-funded initiative through the NIH. Okay, so you may not have heard much about this study before because it's very new. In fact, we are currently recruiting. So this study is about 10 years in the making just to get to this point. The study objectives are to create a new research resource well beyond the NIH. It's really for the entire research community to better understand cancer etiology, understanding the natural history from precursor through to tumor progression, to improve cancer risk prediction, early detection of cancer, and to better understand survivorship issues amongst the millions of Americans who are living with cancer today. This study was designed to address several key research priorities. This is not exhaustive, but these are the main ones. So we really want to tackle emerging exposures, so things that have not previously been studied. So this can include things like new environmental exposures or new behavioral exposures, the interplay of obesity, physical activity, and diet, ultra-processed foods, the role of inflammation and the microbiome, forever chemicals and other hormonally active agents. Vaping is a big one. Cannabis use is a big one. Hair care products, such as Brazilian blowout straighteners and cosmetics, microplastics, and various environmental exposures, and of course, COVID. This design also includes opportunity to explore new biomarkers and emerging genomic markers for cancer precursors through to cancer progression. We have a focus on diverse and special populations, which I will present in a moment. Another key feature, which I think is super interesting, is to address the rising cancer incidence that's occurring at younger ages. So you may have seen some news articles in the popular press, especially focused on colorectal cancer amongst young people. So this is a very understudied topic, and we think that the Connect for Cancer Prevention study offers many new opportunities to get a better understanding of why this could be occurring and then how to prevent it. Okay, so I'll give you a high-level design overview and an update on where we stand with our recruitment. Okay, so some of the key design features of Connect are that we are recruiting people who are free of cancer, ages 30 to 70, and who are patients or members of healthcare systems. So that includes, for example, Kaiser Permanente's, University of Chicago healthcare system, and a few others I'll show in a moment. Our goal is to recruit 200,000 people across the US. We're about 2 years into recruitment so far. And the goal of this cohort is to follow people over a long time, so at least for several decades. To do this, we also plan on having serial assessments, both of surveys and biospecimens occurring at different intervals over this long time period to fully capture people's exposures, their different health status as it changes over time and their aging, and to follow up whether or not they've developed cancer. A key feature is also our digital infrastructure, which is flexible, which allows for new enhancements into the study and future studies that may be added onto the core of the study protocol. This map shows our different recruitment sites. So here we have 10 recruitment sites in a diverse geographic area. Texas is our newest site. We haven't started recruiting there yet. Our plan is to launch that in the fall at Baylor Scott & White. They are funded through the Cancer Prevention and Research Institute of Texas. The other sites had bid for and won a contract to work with the National Cancer Institute to conduct recruitment and partner with us to conduct this study. So where are we today in this whole process? So actually this timeline is truncated. The study actually initiated about 10 years earlier in the design phase, but we hadn't started recruitment until now, until 2021. So here we are. In 2024, our goal is to reach our full-scale ramp-up of recruitment. We did a soft launch in 2021. So this was rolling out all of the digital infrastructure that we needed for the sites, testing the different recruitment materials, and transfer of data from the sites to the National Cancer Institute. And of course, the top arrow here shows retention. So we are now starting to build both concurrently our enrollment and retention protocols, because we do plan to engage with participants over the next 20 plus years. Okay, so far we've reached 25,000 study participants, yay. It's no small feat rolling out a study during COVID. As you can imagine, there were many disruptions in the healthcare system that we had to compete with in order to get this study going on the ground. So overall, This pie chart depicts the diversity of our current study participants in terms of self-reported race and ethnicity. And the table shows different demographic factors of our current participants. So I think we're doing pretty good with our sexual and gender minority participants. We're about at 10%, which is fantastic for really engaging with the LGBTQ community in these healthcare systems. About 10% have high school education or less, and only a small proportion are in this lowest income bracket. And our cohort is predominantly women thus far, which is actually not very surprising for cohort studies. Okay. Oh, yes. And so in this pie chart, we do have 13% of participants who reported being multiracial self-report. We're about at 3.6% self-reported Hispanic, Latino, or Spanish. We hope to bump that number up with the launch of our Texas healthcare site in the fall. We're about at 0.5% Hawaiian Pacific Islander. Again, that's a smaller site in Kaiser Permanente, Hawaii. And we expect that number to go up as well as we reach full-scale recruitment. We're at 12% African-American, self-reported Black, African-American, or African, and 5% Asian, and just about 2% American Indian or Native American. How does this relate to other cohorts and US Census data? So here, this table depicts the different demographic factors. The distribution in our Connect participants. The third column shows US data, which is from the 2020 census, or NHANES. And we are comparing that to the All of Us cohort, which is another NIH-wide cohort, or the Cancer Prevention 3 study, CPS-3, through the American Cancer Society. And so you can see here, we're actually doing pretty well on some of these factors. In terms, a few things I just wanted to highlight, which I thought were interesting. Tobacco users were actually a bit lower than the national average. Our study users reported only about 8% of them are current smokers, compared to 19% in the NHANES, and about 7% in the Cancer Prevention Study 3. Alcohol use is actually a bit lower also than the US national average. In terms of obesity, it seems like we are pretty representative there with that risk factor. And then if you wanted to look at, for example, different ethnicities, so non-Hispanic, Black, Hispanic, or Asian Pacific Islanders, and again, this is self-reported, you can see how we stack up to other cohorts. So I don't want to overemphasize this table too much because we're only a bit over 10% of our recruitment goal. So things could very much change in the next few years. But this information helps us tailor in real time our current recruitment strategies. So if we see that we're falling short with recruiting men, this can help the sites really tailor messages that are more focused on recruiting men, either through social media or print materials, radio announcements, etc. So if you're interested in recruitment science, please drop me a note afterwards, because we would love to talk to you about how we can use this real-time data to improve recruitment strategies. Okay, so in terms of the cancer etiology and better disentangling natural history for cancer prevention, with the scientists behind Connect have taken a life course perspective. So what does this mean? So looking at a wide window of life course exposure, starting even into late adolescence and continuing all the way through adulthood. Because as you know, with cancer latency, it could take many, many years between being exposed to something and then developing a cancer. So for smoking, it's on the order of decades, just for perspective. And then for thyroid cancer, there's an association with high dose ionizing radiation, and that's on the order of months. So it can really vary, and it's important to be as comprehensive as possible if we want to disentangle lifestyle versus environmental versus genetic versus microbiome, and really pulling apart how those different exposures contribute to cancer etiology. So here our focus, the foundation is etiology, which can then inform us on better targets for preventive interventions. So whether that could be screening or smoking cessation, or I'm trying to think of how one could target diet. That's probably the hardest preventive intervention we could do in the United States, but I think you get my drift. Our other focuses are on treatment and survivorship, screening and early detection. Okay, and so in this slide, I just wanted to highlight a few things. So here, the thing in common is we're showing the cancer incidence rate per 100,000 people based on SEER data from the NCI across different age groups. And as you can see, cancer incidence starts to rise quite dramatically starting in age 40 and onward, and is quite low amongst children and early adults. And so that was taken into consideration in the design of the study. So we want to make sure that we collect exposure information further back before the risk of cancer abruptly starts to rise with age. And we also are conducting more intensive serial biospecimen collection with the objective of getting a biospecimen before the person develops cancer, so that we have, so to speak, like a baseline, and then, following those changes over time to see how different biomarkers will change, whether in the blood or in the tissue, urine, or the DNA of the participant. Our focus is also on preclinical cancers. So it's important for us to also understand how those early changes, how we can capture those early changes to understand the natural history of cancer as it develops into a malignancy. At the same time, on the bottom part of this graph, you see survey and EMR, so electronic medical records. And we're going to query both of those components digitally in a serial and intensive fashion as well, to have the most comprehensive assessment possible for cancer and other chronic diseases. Okay. Here I wanted to emphasize an update on the study. So we recently expanded our age range for recruitment from 40 to 65 to 30 to 70 to better address early onset of cancer as an emerging epidemic. So this is a fantastic paper. If you're going to read something on the weekend, one science paper, I would read this one because it really collects, it's a beautiful review and collects a lot of information about early onset and late onset cancers and the emerging evidence of what could be driving those patterns that we see globally, not just in the US, globally. So here, let's see. So what we've seen in national data through SEER is an increasing trend in breast cancer, colorectal cancer, that's been in the news a lot, uterine cancer, and many others amongst people who are under 50. So what we call early onset amongst all race and ethnicities. And as described in this review, there are really specific clinical and tumor characteristics that are different between the early onset versus later onset cancers. So that includes different subtype distributions. Early onset cancers tend to be more aggressive subtypes and have worse outcomes. There's also different types of genetic mutations that occur earlier on in these early onset cancers compared to late onset cancers. It's really fascinating. And it's important to understand why this is happening. It's an incomplete picture. So what we're trying to do in this study is, again, like have a more comprehensive exposure assessment to disentangle what could be driving these trends. So in the early exposure ascertainment, we aim to reduce the different misclassification that has plagued other studies in the past. So recall bias is a big one. And we also want to include contemporary exposures such as medication use, hormone use, and various lifestyle behaviors. We also want to capture early exposures in biomarkers, different markers that are indicative of tumor initiation and cancer precursors. And this slide summarizes what I just said earlier. So here, by expanding the age range to 30 to 70, we now have a larger window with which to focus on precancers and collect these relevant exposure windows for tumor initiation. Okay, so that ends the section on the cancer epidemiology and etiology driving the Connect design. Here I'm going to focus more on the participant experience. So one of the things that is absolutely fascinating about this study is it's all digital. So gone are the days of using paper forms. Today, participants use the Connect app. So it's a participant app through which they receive all of their communications and complete their study activities. So through this app, they get reminders about their biospecimen appointment. It's integrated with email and now with SMS. They complete their study activities, so the 4 baseline modules, and they get reminders for future events that they have to participate in, that they may choose to participate in. We're currently building out a new section in the app to include return of results. So we are planning to return things like diet report from the diet history questionnaire, information that may come from mobile and wearable technology, such as smartphone, watch, or Garmin, that people can choose to participate in donating their data from. Okay. And here they also complete their informed consent and educational modules about the study on the app. So it's an electronic consent process. We have both desktop and mobile versions, and participants are guided to click through the various screens. So the e-consent screens break down the full informed consent into more digestible pieces of information. And we also have a progress bar, electronic signing, and download options for informed consent and the HIPAA release form. So you might remember when you go to the dentist office or doctor's office, you have to sign that HIPAA release. Well, here it's all digital, which I love because I always lose those pieces of paper anyway. So if I could join Connect, I would, and that way I would have everything just in one place. Okay. And this is just an example of how participants receive updates about how to complete their profile or signing their various documents. Pretty easy to use. Okay. And now what about biospecimen collections? This is a whole other beast in the study. So here we plan on collecting a wide variety of biospecimens at baseline. So there's going to be a saliva mouthwash kit that people can mail in or complete at the clinic. We're collecting a few tubes of blood as well at baseline, urine, and then in the future, participants will consent to allow the site to cut H&E blocks from any precursor tissues or biopsies that they may get through their usual routine care with their clinician. All of this information is sent to a central biospecimen repository and processing site. As I mentioned in that graphic showing the cancer incidence and the red arrows of serial biospecimen collection, on average, participants will provide a biospecimen about every 3 years, with more frequent biospecimen collection for participants who are at higher risk of cancer. The digital infrastructure of this study allows us to propose collection of new types of biospecimens, for example, liquid biopsy or stool to study the microbiome. And what's been flexible about the design is that a participant can choose to donate either at their healthcare site, a different external clinic, or at home, with the exception of blood, whatever is most flexible. So we have some sites that are quite rural. So having this system allows the participant to donate, for example, at a satellite clinic, which may be closer to their home compared to driving an hour plus into the main clinic, which is probably located in a bigger town or city. And that's pretty important when you get out to the Dakotas, for example. We also paired this biospecimen collection with questionnaires and other data collection from the EMR. Okay. Switching gears to the surveys. Okay. So we have a comprehensive set of baseline surveys that a participant will complete close to their enrollment time. We have a background and overall health survey, which covers medical history, family history of cancer, occupation, and education. We have a module on medications, reproductive health, sleep, and exercise. So this also covers pregnancy history, physical activity. The third module is smoking, sun, and alcohol exposure. What I think is very innovative here is a focus on an emerging exposure, which is cannabis use, which we know has different prevalence of use in the population based on demographics. So, and interestingly, a lot of participants are filling this out. We don't have many missing data points. So I think that demonstrates the trust that we're building with participants in this study. And lastly, we have a where you live and work, focused on residential history, going back 20 years, and also community. These surveys accompany a biospecimen donation. So we have 3 different components to this. So for the blood and urine donation, we collect information on recent exposures to food, drink, and different medications use. We also have a section on reproductive health. So for women, querying the last menstrual cycle. Then for mouthwash, we have components focused on oral care and oral health, exposure to various mouthwash, toothpaste, gum, and tobacco products, and again, getting at the microbiome component of oral health, whether the person has any permanent tooth loss. We've recently added, semi-recently in the past few years, added COVID-19 exposure to study long COVID, complications arising from COVID, and a person's vaccine status. These are our immediate planned follow-up surveys. So we are currently preparing to launch the Diet History Questionnaire, DHQ, and 24-hour recalls to validate that. So the 24-hour recalls include ASA24 for diet and ACT24 for physical activity. We recently launched the Promise Survey, which is a quality of life survey, with the goal of having this information at baseline, so before a person develops a chronic disease, so that we can understand how their quality of life may change after getting a cancer diagnosis. This is so important to help us understand survivorship issues. And 2 years out and beyond, we plan to have repeat assessments of baseline and also include new exposure assessments, for example, on hair and personal care products, naphthalene, and other scented products. I think one of the most fascinating topics I've encountered thus far in Connect is really the use of personal hair care products, because you see this in the news and various blogs and social media about how, different straighteners used by women of color, contain potentially hormone disrupting chemicals, and the long-term health effects of these products is unknown. So it's pretty exciting to be involved in a study that's querying that over the course of a person's lifetime, so that we can really disentangle whether these are indeed causally associated with cancers or even other chronic diseases like cardiovascular disease, etc. So one of the nice things about Connect is, of course, we're focused on cancer, but many of these exposures also overlap with other conditions. And so if a researcher is interested in partnering with us, we're flexible to incorporate cardiovascular disease outcomes and other outcomes like depression and mental health. Anyway, something to stay tuned on and watch very carefully. Okay. And then 3 to 6 months after a person develops cancer, we're going to identify that information using a special algorithm called a rapid case ascertainment, which queries the electronic health record. And 3 to 6 months post-diagnosis, we will send that participant a cancer diagnosis survey, which queries their symptoms, how their diagnosis was worked up, whether through imaging or biopsy or genetic tests, their weight, and their updated medical history. And at that point, we will also issue them a repeat assessment of the quality of life survey. Okay. I know I'm going very fast. I'll try to slow down. So in addition to having individual self-reported exposures, the study also plans to do linkages to external sources of data to complement the information. Connect will link to state health department cancer registries, the mortality information coming from the National Death Index, external healthcare records, potentially from Medicare or other electronic health records if a participant leaves their current healthcare site to go to a new healthcare site. Other health outcomes that come from state health departments, such as HIV registries, and geospatial data covering all kinds of EPA environmental exposures and US Census information. So there's a whole slew of information we plan to link on for that. Outdoor air pollution, outdoor air quality, water quality. It's quite vast and quite complex. But one of the fascinating things is that, again, we're so flexible that we have enough information to then triangulate back to these other sources and have a high quality linkage. Okay. Yes, and so with the geographic information, we're going to be linking to numerous different risk factors and exposure information. And we are currently exploring some other field studies to pull in geocoding for address, for residential address and work address. Okay. Lastly, I'll end on our resource access principles. So you may be wondering, okay, this is great. How can I get access to some data if I have a study question? So we are still in the middle of recruiting, so no data is accessible just yet. But the steering committee for the Connect study plans to make data accessible to all through a vetted researcher platform. So overall, Connect is planned to be a research resource for everybody, not just the NIH. We're going to have broad data sharing policies and procedures in place to protect participant privacy and confidentiality. So no identifiers will ever be released outside of the coordinating center. And we also employ a FAIR data infrastructure. FAIR stands for findable, accessible, interoperable, and reusable. So none of the infrastructure is behind a firewall. You can access the same infrastructure that we use for Connect and apply it to your own study. We make all of the code accessible on GitHub. And if you're interested in using this open source software, you can certainly email us and we would be happy to collaborate with you on launching that. This is a summary of all the different data sources that will be made accessible in public data sets for researchers in the future. So other NIH investigators, extramural grantees for the NIH and NCI, international investigators, industrial partners, and our integrated healthcare system partners. Okay, and if you'd like to access the study protocol, the consent, or more information on the baseline surveys, you could find us here on GitHub. It's very easy to sign up if you don't already have an account. It's free. And this is really the best place to find everything right now. It's the most up-to-date source. And if you require any code, you can also find it in this space. Okay, so that concludes my talk about Connect. I hope that this has sparked your interest about potentially joining us for a fellowship in our division. The Division of Cancer Epidemiology and Genetics focuses on a wide breadth of topics, ranging from molecular pathology, the microbiome, infections, etc., and of course, genomics. So there's a little something for everybody. And if you're interested in fellowships in epidemiology, genetics, or biostatistics, or data science, you could find us here, explore the website, or you could follow us on what was formerly called Twitter at NCI Epi Training. And here, this is not an actor, this is one of our PIs, Dr. Mustafa Abu Kabar, who leads the development of the virtual tissue repository for Connect. And so he is a digital pathologist in the Integrated Tumor Epidemiology branch, one of our superstars here at NCI. Okay, thank you. So I will open it up for questions.
Does anyone have any questions for Dr. Horner?
There's a question in the chat from Dr. Alcala, who says, are you assessing exposure to stress and trauma? For example, adverse childhood experiences or racism or homophobia?
This is an excellent question. We are working on developing a new module for social determinants of health. It includes stresses, which can be attributed to experiences of structural racism, individual level racism, domains such as neighborhood cohesion or lack of cohesion due to various systemic racist practices in the US. That module, though, is not quite ready for prime time. We haven't launched it in the field. It's still being developed and written. That is one of our next modules that we plan to launch within probably the coming year. In terms of adverse childhood effects, I don't think that's a focus of the new module. I think it focuses mostly on adult stress levels. Another topic we're exploring, which the details still need to be ironed out, is how to correlate those self-reported experiences back to markers in the blood. So, we all know that stress increases a person's cortisol level and is associated with low-grade inflammation in the body. Can we also measure that and Connect and correlate that back? I think that would be a very powerful way to tie in the social epidemiology with the biomarkers to really start to understand how these factors impact the progression of cancer. Yeah, that's a great topic, very timely. The person you would want to talk to about that is Dr. Wayne Lawrence. He's been leading that module.
Are there any other questions?
I have a question.
Denise?
Yeah, so I have a two-part question. One is related to the question that was just asked, because I was going to ask about social determinants of health. But the one thing I do aging research, so I was thinking of this concept of inflammaging. And so I just wasn't sure. You may have mentioned it, but I may have missed it. Like that I think could be a great opportunity to think about what the effects would be of these, ongoing stressors and inflammaging, and whether that is contributing to the cancer. And maybe you're already doing that, but I just wanted to ask.
We're not already doing that. We haven't operationalized that yet, and we don't have any a priori specific aims to look at inflammaging.
It's hard to say.
Yeah, it's hard to say. It's a tongue twister. But I would stay in touch, because in the coming years, we're going to open up the data access, and you may want to submit a proposal to look at that in Connect.
Okay.
Yeah, that's a really great topic, and very timely as well.
And then my second question really has nothing to do with necessarily the research, but I love that you have this sort of ability to consent sort of through the use of technology. But I was just wondering, like, from an institutional review board perspective, our IRB really likes to see that we've assessed their ability to give consent. And so it doesn't seem like that piece is there. Now, maybe it's population specific, like we study older adults again, right? So I was just wondering, has that been a problem at all? Like, I guess that's not a problem.
So do you mean like whether somebody has the cognitive capacity to consent, or
Yes.
whether they've truly, okay. That is something I'd have to follow up on. There was a very detailed review by the NIH IRB for the informed consent and the e-modules. So a person does have to click through all of those. They're little educational screens before you get to a long form. So it helps break it down. Because, I read the long form consent and I was like, oh my gosh, this is like my Verizon bill. Like, who reads this fine print, So we can't expect an everyday person to go through all of that. So we deliberately made these e-consent digestible bits so that get the most salient pieces of information before they sign anything, in addition to getting the long copy. But so how that impacts people who have cognitive issues, I would have to follow up and get back to you.
Okay, thank you. I appreciate that.
Yeah. One of the things that is interesting, though, about the whole digital component is, are we somehow, does this approach somehow bias who we're getting in the study? And, so are people who are just less comfortable with digital platforms, like maybe they just have a lower digital literacy, are we missing them? And that could be for any reason. It could be folks who just don't have a laptop at home or a tablet, or they're just not comfortable going through long apps and websites that ask you a lot of questions. So that's something that's always on our mind. Like, are we truly getting a representative sample through this design? And how do we make sure that the platform is equitable? It's tough, though, because you want to make it easy, but you also don't want to exclude people.
Right. It's a balance.
And so that's something we're constantly discussing with the sites. And we do have opt-out reasons for people who choose not to join that we are examining. So, sometimes, like, one of the fields that's captured is it's too complicated, or I don't have a cell phone, or I I don't know how to read the website. So that's something we do analyze also in routine basis. It's tough. Yeah, it's tough
Yeah,
running a
tough.
big cohort, and you want to get everybody, but it's not always possible. You know,
Yeah.
you have to be practical at some point.
Yeah. No, thank you very much.
so we have another question in the chat from Nam. And her question is, do you give an option to complete the consent process in person?
In person. So do you mean with the assistance of a staff member?
Yes, that's what I meant. I think often for older adults, because of the technology competence issue, we consider that it is better to offer multiple options. And
Mhm,
also for the online consent form, I think the validity of the person, right? I
mhm,
think that's another thing that we often add to after the consent process. We somehow like using the phone, we verify their some demographics, because since we don't know the patient, and then Denise mentioned the cognitive abilities, so always it's better to have that second layer. But I
mhm,
was not quite sure what is the process, but I agree with you about the technology accessibility, also the competency. So
mhm,
to recruit this level with the scope, I think I was thinking that maybe giving them options, especially
mhm,
for older adults, could be a
mhm,
good strategy and fair
mhm,
strategy, right?
mhm. So I'm not aware that that's one of our strategies, but we did get feedback from this one of our sites that they do have staff members who are sitting with some participants who are having trouble completing the baseline enrollment, which includes the consent. And so based on that feedback, we've started discussing whether that should be like how do we make that an option? Like, should we make that an option, and how do we make that an option for all of the recruitment sites?
Yeah.
And what would the cost be for doing that?
So
Yeah, because you require staff members then, right? Like, but
yeah,
so
yes, and
yeah.
also I think in the past we used. I know that it's another technology, but for example, the secure virtual meeting format. So
Mhm,
in that case, I think sometimes many older adults have smartphones. So sometimes we found that their family members help them to kind of get used to the virtual format. So sometimes we using that virtual format before our older adults start modules or consenting form, we kind of go over that with older adults and their caregivers. We found that works also well too, because older
mhm,
adults feel more comfortable.
mhm,
So we use
absolutely.
variety of methods, but I do think that giving them options seems
Mhm,
to be fair thing to do.
absolutely. Yeah. I'm going to bring that suggestion back to our committee to discuss. I know we do have a question on one of the baseline forms. Did a family member or did a friend or family member help you complete the survey?
Yeah.
And so we did start analyzing that information on the initial round of participants that we have in this study, just to get a sense of how much of a need is there, so that we could plan around that.
Mm-hmm. Yep.
And so far, it hasn't been a large proportion, but my concern is that a person who has trouble completing the forms isn't going to do them, and we won't, and therefore we won't even get the information that they're not doing it, right? It's like a kind of a catch-22. Like if they're having trouble, we will never see them in the data set. So,
But the other way
you
is that sometimes older adults initially they don't feel confident,
know, mhm,
and then they worry about it. But once we show them how easy it is, how easy to go through it, but sometimes kind of attitude can change. So
Mm-hmm.
I know that the personal time is kind of valuable and then expensive, but just that was experience. Because older adults, they can learn and use it, especially if the user interface is easier, user-friendly, then they can pick up pretty quickly.
Yeah, these are great points that I'll bring back to our communications and engagement team.
Yeah, thank you.
Yeah.
So Catherine, you have your hand up?
Oh yeah, hi. I had that was a great talk. I really enjoyed hearing about the study. It sounds like you're building an amazing resource. So thank you for sharing all this with us. I had a question about the residential histories. You mentioned having that data. Is that based on participants reporting that on questionnaires? Are you linking with LexisNexis, or just curious how you're going about getting the residential histories?
Both, yes. So it's primarily self-reported. And when we do the geocoding, which we're starting actually this month, the first batch of geocoding, we will use LexisNexis to help fill in some gaps. That's especially important for more rural areas. If we, we might just have like a PO box. So, we need to get the latitude and longitude for the geocoding. And so it's a bit more challenging. And the further back in time you go, like the names of streets change. So you have to reconcile just the changes that occur in a town versus what you could find contemporaneously in our data sets now. So we're doing both approaches. We haven't really looked in depth at that data yet because we're just starting the geocoding.
So I don't see any more hands up. If nobody else has a question, I would like to say that was a wonderful presentation, Marie, and a wonderful resource you're developing. When do you think that you'll start making data and biospecimens available to the research community outside of NCI?
Yeah, oh gosh, great question. I'm going to have to punt that one to our senior scientist, Mia Godet. It will be a couple of years, I think, but we are planning to have a workbench with aggregate data sooner than that. So the aggregate data at least will allow people to start planning proposals and do power calculations and, at least then have something that they could put in a grant application. So that I think is closer to being launched than individual level data through a workbench. I wish I had more information. Unfortunately, I don't. It's a super common question, and I just don't know when we're going to have it. It's not going to be at least for a couple of years.
Okay. Well, another question. NCI or NIH recently launched the All of Us cohort as well. And so how do these two resources relate to each other, or do they?
Sure. So they are independent cohorts. So All of Us, let's see, the core differences between All of Us and Connect is that Connect is cancer focused. So the design more specifically addresses how to capture serial assessment for cancer in terms of the biospecimens. So we have more serial biospecimen collection, more serial survey collection, whereas All of Us, it's a pretty broad cohort looking at many different types of outcomes. So anything from cancer to mental health to diabetes and beyond. So and they do have biospecimens as well, but not in this type of in-depth collection that would be required for new innovative assays such as liquid biopsy, right? So liquid biopsy is a pan-cancer assay from just a few drops of blood, right? So looking at molecular changes in cell-free DNA in the blood that could predict a person's risk. Very cutting edge and novel. There's something on the market now that hasn't really been fully evaluated yet on a population level. And so all of us, I think, it's just a different design. So you can't go as deep into questions like that with all of us as you could for with Connect for examining cancer etiology. That's the core difference.
So, but with Connect, I can't imagine you would not also collect data on other outcomes besides cancer, heart disease, diabetes. Are you planning on collecting those outcomes?
Yeah, so we will get those outcomes through the electronic medical record, and we certainly could collect those as well through state registries. We are collaborating with another institute at NIH, the National, oh gosh, the acronyms, NHLBI,
Heart, lung, and blood.
Yeah, lung, heart, and blood, to do a pilot on cardiovascular disease. So various cardiovascular disease outcomes, such as, rapid onset heart failure. How quickly can we find that in a medical record? Because we're going to have all these blood samples that would also be informative for other outcomes. So we're exploring that. And so we certainly could pull in other outcomes of interest to researchers, probably more in the chronic disease realm versus infectious disease realm, just because infectious disease could be so acute. It would be hard to study in a cohort like this in real time.
So we have another question in the chat from Jim.
Mm-hmm.
Just closed down on me, sorry. Regarding EHR data, does Connect data have direct access? If not, how do you collect them?
I'm sorry, if not, how do you collect them?
Jim, do you want to clarify?
Yes, regarding EHR data, sometimes when you collect the data, you can put a direct link from your database or the structure, or sometimes they collect the data using some other way. So for the Connect, I was not certain how you collect the data. It doesn't seem to be like in-person chart review.
That's right. It is not an in-person chart review. The sites and our coordinating center are developing an API to basically do monthly transfers, monthly or quarterly EMR transfers.
I see.
To the coordinating center. So it's not direct.
Yeah.
Yeah, that's a good question. I don't think it would even be possible to do it directly.
It's complicated. That was the reason I was. That was the reason I asked. Because it sounds like it's a batch process.
It's a
monthly.
batch process.
Yeah. Thank you.
Yeah.
So it's after 1, and so I think we have. There are no more questions that I see. I think we're going to have to end. But with just one quick question, are your fellowships open to international students?
Yes.
Okay, good. Okay, well, thank you very much for a wonderful presentation. We all enjoyed it. And we hope to be hearing from you some more.
Thank you so much. Have a great day, everyone.
Bye, everybody.
Thank you.